Good evening, New Bedford Guide viewers, and greater New Bedford followers. Chris Resendes back for the Chris Resendes Show episode, 2018, second episode of the year. We're going to go and touch back upon a subject that we had discussed prior. We had the opioid crisis. We had prior guests from different parts of the epidemic, whether they were victims that their families had lost somebody, with Wendy. We had recovering addicts who are now helping with a few guests. And now we're going to go through the medical aspect of the epidemic. We have two doctors in the house. Both of them I've sat down with before to discuss the matter. Actually, Bonnie reached out to me the week that one of the guests was here, and I was kind of trashing doctors, and wait a second, we need to talk. And it's good because to every issue and everything in life, there's many sides to the story. And here we are revisiting an important topic that really needs to be spoken about more often and brought out to light. And now we can look at it from a medical aspect. And then you're in charge tonight. I already talked to you about this. We got Dr. Mike Rocha, Hawthorne Medical, and he's also New Bedford Wellness campaign that you do. He's involved in everything. I tell him I don't know how he does it. I look for a couple hours a day extra. He needs about 7 more hours a day. The guy's always busy. I don't know what he runs on, but I need some. Thanks, Mike. Thanks, Bonnie, for being here.
Thanks for having me on.
We're gonna just start off real basic. When I discussed the topic with I don't know if it was Jamie or I don't know which guy it was, but I really got passionate about Big Pharma and doctors' roles in the opioid epidemic, which started back like 96, 97. At the time, you were just in your residency or starting?
I was in high school.
In high school, all right.
Yeah.
So you had come in already a few years later.
Yeah.
Just to give everybody a rundown, 1996, Purdue Pharma introduced the great OxyContin. It's a painkiller, and they did some testing on it, and they said it wasn't very addictive. Well, 2018, we all know that's not the truth. Key components of this effort to get this drug out were they would talk to people about pain management, and they would invite people out to Florida, San Diego, and to these conferences and tell all these doctors and pharmacists and nurses how great this OxyContin was for their patients and how it was great for their pain and it didn't make people sick from the aspirin and the Percocets that they were used to handing out. And this is at a time where they were using at the time they had now started using the pain, the little smiley faces and all that. So it became a pain management issue, and you had discussed this with me that one time we sat down. Mike, you said the fifth vital sign became this pain management.
Yeah, fifth vital sign's a big. It was we have really struggled with how to deal with people's pain because now when you have stronger medications, the idea is that we should have zero pain or something along those lines. But pain actually, in some ways, is good for us to have a little bit. So it kind of you have to.
It's an indicator of what we're dealing with.
Right. And actually, it's interesting for example, for people like diabetics that have neuropathy, so they're unable to feel their feet, they don't feel pain. That they're at risk for having very serious infections. So there's a balance to everything, and I think that the idea that that we can alleviate pain is important. And what we're going to talk about is it's not an all or nothing in terms of using opioids. It's using things that are appropriate in the certain settings, and I think that there's different kinds of pain as well. So we sometimes think that pain is one thing, and there's various kinds of pain, and certain pain medicines do better than others at treating pain.
Now, Bonnie, early on in your career, you were in the ER a lot.
Right. Before I went to medical school, I began working in the ER, and I worked full time through college. That was how I paid for my college. Up until I went to medical school. And then when I went to medical school, we had to be paired with a doctor to kind of be our mentor.
Yes.
And initially I thought I was going to go into emergency medicine. I was there as much as I could be down in the ER at the medical school that I went to. And the doctor that I worked with, he was referred to as the candy man.
The candy man.
The candy man, yeah. And, he kind of initially had shaped how I thought about pain, in that he told me, you can't tell somebody that they're not in pain. It's a very subjective thing. For me, what might be a number 2 on this pain scale could be a 10 to another person. And who am I to tell them that their pain is not actually at that level? And at about the same time, I was being, during my training, it was, if you don't mark, this pain, the people's pain level, that it's a billable thing. You have to, in order to, and it's a JCO thing, it's a regulation for hospitals and being accredited and that kind of thing, that you have to mark it and mark people's response to medication. But I don't recall being taught that you have to tell people that you may not be able to completely resolve their pain. So I think people have a lot of expectations that when they take a medication, or a doctor prescribes a medication, that they're going to be completely pain-free.
Yeah. I mean, what confuses me in the way that this stuff was handed out was, I hurt my back. I was an athlete. I've broken every finger. I snapped my forearm. Went through my growth plate of my ankle. There wasn't anything I did not break. I never once really. I took some Vicodin, I think, to sleep one night, and I never really even took Percocet because I didn't like it. It didn't make me. But now you got people that just not now. Prior to this awakening, you were getting these people going into the ER all the time, and it seemed like the ER was a big problem with this, where they were just going into the ER all the time and just getting these pain meds for minor stuff that shouldn't have been getting these hardcore OxyContin pills and, the prescription for 3 or 4 or 10 or 15 of them at the time, And I think that the jump start of the epidemic really started almost in the ER, from what I've read. A lot of the in and out. Here you go, get your pain, you got this, see you later, go see a specialist. Here's enough to get you through to your next visit.
Well, and, before they implemented drug monitoring programs that, doctors could log in and see where people, received a prescription, or how many they've filled and how many actual pills they've encountered, a doctor couldn't tell if somebody had gone to, the ER down the road, unless it were in their system per se, their computer system. And they couldn't tell, if they had gotten a prescription and they had gotten it filled yesterday. And I think that from a physician's standpoint, at least mine, the thought that, I can alleviate somebody's pain and be compassionate and empathetic towards them and make them feel better, I think kind of that pendulum swung. And so there was this medication that could really make people feel better and function and be able to get back to work. And that was what kind of, I think, was glamorized about it and marketed about it, but the side effects from it were not, the risk for physical dependence and then the withdrawals that could happen from it. I think that we lacked, from a medical standpoint, I think there was a lack of education for patients, and then I think it kind of snowballed from there. Yeah.
You were talking, Mike, earlier about people not going. It was a total separate matter. We were actually talking about, I think, heart disease or whatever, but prior to the show, people not really looking into the studies.
Yeah, so speaking, there was a study, one of the studies that really fueled the epidemic was actually not even a study. In the 80s, there was a paragraph that was written in the New England Journal that said that, these medications when given, and it was actually in a hospital population, that if they're given for pain, that it's really not addictive. And what we've really found is that's not the case. And we have to make sure that it's very easy to interpret studies in various ways. And, again, we have to be very careful in the type of study. Whether we're looking in the rearview mirror and looking at an observation, it doesn't always mean there's a causality. And that's a really important thing, is that when we're trying to, I would love for everything to be a very simple solution to some of these things that are very complex problems. And I think that what we need to make sure is that when we're looking at data, that we have to look at the quality of the data as we try to make the decisions, and that we all from a medical perspective, that we look at these things peer reviewed and rigorously, or else we can be led down paths. And I think that that's actually, interestingly, some of the things that we use for data saying that that these weren't highly addictive medications comes from data that really wasn't very strong.
Yeah.
And if you say something enough times, you maybe believe it, right?
Absolutely.
So, and then once you feel that that's you don't even go back to the original study, because doesn't everybody just know that's the truth, right?
Yeah.
So that's what the challenge is. And I think that as we try to find our way out of all of these things, that there's certain unintended consequences that certainly went on. I think that some well-meaning people, physicians, were actually trying to be reasonable and try to alleviate pain, and sometimes I think on a lot of people's ends, they didn't realize how easy and how quickly people can become addicted. And I think that is, and everybody's different. And one of the things that we know specifically is that, kids are much more prone to the throes of addiction, and much more vulnerable. Again, the developing brain after about age 24 or 25, there's a much lower risk of addiction when exposed to various substances. I know we focus mainly on, opioids, but we're also, we have to keep in mind that there's many substances out there that are very addictive, and understanding the science behind it is very, very important. And I think that if anybody out there gets an opportunity, Ruth Potee's talks are excellent, and they do a very nice job. She's a family physician out in Franklin County. We've had very fortunate to have her come down here and talk a few times, but she's been very, very well versed and has explained how the science of addiction really becomes such a problem that brains get hijacked after there is that addiction.
Yes. Just to go back on one thing you said, is it normal for a medical journal, such as a prestige one, just to have one paragraph to?
No, it isn't.
To set a precedent, I guess, in medicine? And it's not.
It's not. And I think that if anybody really, and I think we've talked about this before, but a really well done book. In fact, Sam Quinones was just on a panel down in
my notes.
Down in Washington, talking about really how we got to where we are. And he did a very nice job in his book Dreamland, describing how do we get into this mess. And he really kind of pulled back the hood, so to speak, to kind of document, again, step by step, how did we get into a prescription drug issue, and then how did we then subsequently become vulnerable to heroin and illegal drugs.
Now, Bonnie, back to the emergency room. I really want to get through the point of the infancy of this epidemic, and to me, from what I read, a lot of it was started there and kind of moved around, and a lot of it was based on.
Well, think of where people come in with their pain.
Absolutely.
Their first, entrance.
What would be the average prescription that one would leave the emergency room with? I know it's kind of a general question I'm asking you, but are you giving them out 10 days worth? Are you giving them out 3 to 5 days so they can get to a specialist? How does that work?
Well, now I believe it's 3 days.
Well, let's go back.
But
let's
back
go back
then,
to the infancy.
But
yeah.
back then,
there was no.
I don't really think that there was a rhyme or reason.
It was just go and here you go. Because I know I've had friends that have had surgery, family members that within a week they didn't take that pill, they felt sick.
Right.
So to me, like this, I couldn't tell thing. Kind of two things. They didn't really know because they were giving out so much that they didn't have to deal with that patient anymore. Or if they were given a little bit, like, hey, you got 3 or 4 days to get to a specialist. That guy never, if you did it that way, the guy would have come back and said, hey man, I'm hurting, I'm sick, you gotta give me more. You know what I mean? I'm feeling like not good anymore. So maybe that's part of the reason why they didn't catch on in the ER as much.
Well, I think that, one of the things you could also has to be broken down are people's access to healthcare. Can people actually get into the proper provider within a period of time? Can people, if people don't have health insurance, they've just gone to the ER, they've just paid, however much it is out of pocket for whatever medication they need.
Yeah.
Can they, if they're homeless, do they have a ride? Are they working? Do they have kids?
So they were unable to follow
There's
up.
a million different.
Yeah. Now, one thing that we had spoke of and that I never really thought about, and it's gonna move. We're gonna move on to the next topic in this discussion when it comes to, and I'll segue it with this. How many patients did you Narcan in the hospital because you guys were ODing people on pain meds?
Personally, 2. I think that was too many.
That caught me off guard, quite frankly.
Well, during my intern year, we had a lecture on how I had learned about the chemical makeup and how how Narcan works, but never really like the dosage and stuff until my intern year. And we had a 15-minute part of our lunch lecture about how to do it, and I was on night float, which is when you're running around the hospital taking care of all the patients because your fellow residents have gone home. And I've had 2 calls during I think a 6-week period.
Yeah. So
to do that.
It basically just sounds like it caught everyone off guard, including the physicians prescribing, and that's how it got out of control. And then it incorporated greed afterwards, which you can talk about as well, and the doctors getting graded per visit, how does that work, the grading system, Dr. Mike?
Well, so grading systems are very, again, are very variable. But again, I think that the oversight, again, quality metrics, everybody's looking at these, how well do you perform, how well you perform against your colleagues. And, again, as certain regulatory committees come in, JACO, et cetera, have kind of, people were getting graded on how well they were managing pain. So the thing is that sometimes these quality metrics get tied into reimbursement. Again, these things become very complicated. So and we're just talking about pain management, but there's various things that doctors are constantly being scored on. And sometimes what we find, though, is that sometimes what we're looking at are the unintended consequences of what we're doing, right? So if you're measuring something that ultimately is not a quality metric, meaning it's not getting the outcome, but we're measuring. Sometimes we do a lot of measuring, and I think that measuring things and observing and looking for quality is important, but sometimes we've overdone it in some ways, and now we have to kind of step back and go, is this the right thing? Is this what we should have been doing? And so I think that right now, obviously, things have dramatically changed. And, most people have had, over the last several years, of conversations, amongst hospital organizations that they've recognized that we need to do things differently in terms of how we're managing pain.
Yeah.
And I think that, again, our healthcare system struggles tremendously with chronic disease management. And chronic pain is chronic disease, right? Yeah. And whether it's heart disease or hypertension, these things we have a hard time because it takes relationships, time, listening, and what has happened to doctors' visits over the last 50 years is that ability to sit and listen has decreased. And the other thing is when you look at pain management, there's been a strong push in the last year to really bring to the forefront things, physical therapy, alternative therapies, using NSAIDs when appropriate or Tylenol when appropriate. Again, this trying to deal with appropriate use for the different kinds of pain that people may be experiencing. That again, many of which may not even be that opioids aren't necessarily the most effective.
Yeah.
And I think that what we need to do is to make sure that we're all having conversations about, okay, how do we treat pain in a reasonable way? How do we have a conversation with that patient? And what it really does is we need to really get back to having high quality primary care where you have a relationship with your doctor and you have the opportunity to really start to explore. other ways of managing your pain. And, we used to treat back pain and people would sit in bed, for weeks, and what we realized is actually that may be one of the worst ways to treat back pain, that you need to get up and move,
stretch and
and
move
all
around.
those other things. So I think that what we've looked at is that renewing a conversation with things that may be able to decrease pain that we haven't been talking about because, unfortunately our visits are very quick. It's very easy in some ways to prescribe something. It's much more difficult to have a conversation.
You've brought that up a couple times now. Our visits are fast. Our visits are fast. Is that based on the number of doctors to patient ratio, or is that based on insurance telling you how a visit? Because that's part of this problem. Also, is insurance companies, and you got to do A, B, and C to get to D. I mean, you deal with it all the time. And are they to blame for this poor quality service, poor customer service, like I'd like to refer it as, that you're not able to provide like you used to be able to?
Well, I think that medicine has, unfortunately, has its priorities upside down.
Yeah.
And I speak for that as a subspecialist, so I'm a cardiologist.
Mm-hmm.
So subspecialists get disproportionately reimbursed for their services because they have different billable activity. Meaning, so if I do a procedure or we do a study, that's a reimbursable activity, whereas we don't reimburse time and listening and compassion in a meaningful way. It's not something that you can put down, but on the billing sheet. But the most important thing is really ultimately that relationship. And the most important patient is the most important doctor, for the patient is themselves, to help empower them as to how they're going to learn how to sometimes manage. Give them the tools that are necessary, and that unfortunately can't happen in a very quick visit. And I think that what we need to be able to do is not only recognize that healthcare has to exist in the office, but health and well-being has to exist outside of that. So we need to actually invest in wellness, which is really what we're talking about in some ways, and prevention, but wellness in such a way that people have access, where it's not, you don't have health, the health club level of wellness, that everybody has access to things that can be helpful to them. Because I think that we don't have equity or equality in the way that people have access to things.
Absolutely. We got a question from one of the guests on our show that we could go live and they ask questions. Doreen Santos brings up a point that you hear all the time, and basically she just says pharmaceutical companies are making money. Bottom line, they're making money, and they actually wanted patients to get hooked on this medicine. How do you feel about that as a medical professional, Bonnie?
I think that the kickbacks that were given out were, I think, partly responsible for some doctors turning, the tide from being, they're altruistic to a selfish kind of approach.
Yeah.
The doctors who charge, don't take insurance, you pay, per script and go in and see them. And, we've all heard about, Michael Jackson and the doctor that, was giving him the propofol, the drug that,
the crazy stuff.
Yeah, exactly. But there are unfortunately doctors who do that. And, before my time, before, my training, it was, vacations and such, or trips to conferences that were paid, and you're put up and bring your family, and it becomes, a really nice vacation. But kind of back to the office kind of thing, we don't have enough primary care doctors, going right back to that. And I don't think that they're paid enough. But
is that the issue? Is the
think
issue
that's
that
a huge
insurance
part of
is
it.
not paying these primary care doctors enough for them wanting to stay in that profession?
I mean, it goes
or that
to
part of the profession?
if you can't pay back your loans, and not kids, but young doctors are coming out with $150,000, $200,000 on loans on top of what they had from college, and then add on that they're not getting huge salaries during residency. I mean, I was working the 80-hour work week that I was in the hospital, then whatever I was doing at home, and my take home was 50,000, which comes out. You know, I think that's a really nice salary for
not
most
for 80 hours a
people,
week as a
but
physician.
I mean,
Yeah,
and,
no.
if you come out into primary care, you're not making as much as your cardiologist counterpoint because of things like procedures and the more complex billable things. So
now, how does that work billable? Like you sit there in front of a computer screen, and you do. I've witnessed it at my. Unfortunately, I think my son's going to follow my path in the emergency room. This, that, and then check this and check that, and we did this, and you see them doing it. And it's basically like you hear the old-fashioned.
Oh, and they hire people to go back and review what you've documented in order to be able to bill your insurance at maximum amount.
Is that basically like your roadmap for treatment? Is with the billing on the left and your treatment on the right? Like, no, okay.
No, it shouldn't be.
But it seems that way.
I think the documentation has kind of gotten,
way too much. But that's with everything.
Yeah, that's.
I was talking to a probation
is,
officer today who's just like, I can't do my job anymore. They
Right.
want me to be a probation officer, but they want me to sit here and write a novel every day,
Right.
and paperwork, and it doesn't work that
Right.
way. Just once again, guys, tonight we're talking with the doctors on New Bedford Guide, Dr. Bonnie Boerl and Dr. Mike Rocha, the famous Dr. Mike Rocha, who doesn't sleep. Today we're discussing the opioid crisis. We'll touch upon other things, but we're really touching upon the insurance involvement, the medical professionals' involvement, and the pharmaceutical companies' involvement in the opioid crisis. We've touched upon the infancy when small studies were released and saying, hey, here's OxyContin, it works great and people don't get addicted. And now we're moving on to other topics for those just joining on. Let's move on, Mike, to Mike is a guy who tries not to prescribe you medicine. You're the antithesis of what we're discussing tonight. Mike's like, you know what? Go eat a soup. Go walk around the mall all day, and don't smoke, don't drink, and you'll be fine. I won't have to give you as much medicine. And that's awesome. That's how medicine should be. Like you said, it should be outside of the office as well. Mm-hmm. When you're doing these procedures, there's obviously pain involved when you're cracking a guy's chest open, and you've been doing that for quite some time.
I don't do the surgeries.
You don't do the surgeries?
Yeah,
all right. But you're still dealing with the after effect of a surgery. How is there a balance now throughout this let's fast forward now to 2018, now with regulation and finally people admitting that the stuff that is killing people and starting an epidemic, I think it's 1 in 3 people that actually have taken OxyContin get addicted to it at some point. What are they doing now to train doctors? Is it just you got to go to here? Is it mandatory as a licensed physician to take these classes on addiction now? Or
so they've definitely made over the last several years, at least in Mass, every state has different regulations in terms of classes that you need to attend that are going to be, as they call them, the risk management type classes, but the courses are focused in on pain management prescriptions. So I think that training has definitely changed, but also guidelines have changed. So in the last year, the CDC actually did a very good job of some reasonable recommendations on how to prescribe medications. And again, similar to what happened in Massachusetts with some of the things that Governor Baker has done, is really the least number of pills possible to treat pain, and to try to also make sure that people realize the risks of those associated. Again, cutting it down that the supply is less than 7 days, and for kids it's less than 3 days, and that
they're at a higher risk, like you said.
Yeah, absolutely, and that people actually had this idea that you could do a partial fill. That you didn't even, if they prescribed you medication, you didn't have to take actually the whole prescription. And I would say that, again, so for what I see for the surgical patients when they come to see me afterwards for open heart surgery, I would say that in general, the surgeons have been, at least the cardiothoracic surgeons, have been giving less opioid pain medications after having surgery. And, I think that in general, everybody in the medical profession or most people have been trying to really reel in, the prescription end of things. Unfortunately, there's many people out there that are already in the throes of addiction, and the truth is most of our overdoses that are not from pills are heroin, but actually really fentanyl. And so the issue is that, we're dealing with things that are 50 to 100 times stronger or more potent than heroin. So I think that the doctors in training are definitely much more sensitive. I think that there has been, again, I'm not in medical schools these days, so I know that there has certainly been a push that there should be more training. I think that there has been more effort to getting people that are certified, so to speak, for addiction medicine, but also, we had David Casavan, who's great. He's from Children's Hospital, and he came down a year ago and did a nice talk. We had 80 doctors talking about pain management. So I think that, making sure that we're doing a better job on pain management and limiting the number of opioid prescriptions. Again, for people, it may be appropriate, right? Again, it's not all or nothing. And I think that what we also have to realize is that there's some patients out there with cancer pain or in hospice care, or that, or have pain that does respond. And it's not about taking away everybody's pain medicines. It's trying to do it in a reasonable way that we're not over-prescribing. And I think that because there is a backlash. There are some people that say that, we're trying to take everybody's medications away, and that's actually not the case. We're trying to make sure that we balance the risk, because that's what we're trying to do, is reduce the risk.
Yeah. Now, we're at a time, Bonnie, where 1996 wasn't that. I want to say it wasn't that long ago, because I want to feel young still, but it wasn't that long ago. I'll say it. And prior to that, we didn't have OxyContin, and people lived. People had open heart surgery. People snapped their legs. People lost their legs. People lost limbs. Fingers, and they managed to get through it. Is it something now during that time period where once this super pain drug came out, that here, we're just going to give this because we don't want you to be in any pain, like Mike had touched upon?
Well, think about, when a woman had a baby, she would be in the hospital for a week, 2 weeks, and now, 2-3 days.
They're out.
So,
which my wife liked, because by day 2, she's like, get me out of here.
That's a whole another topic as a mom myself. But, we have, the medication that can help get people out the door faster.
Yeah.
Insurance companies don't want to spend $10,000 or $5,000 or whatever it is to have somebody every day in the hospital, which.
So it seems like we're just going to keep going in this circle.
But the insurance companies, I think, also don't necessarily want to pay for all the wraparound services that people need when they get home, like in-home physical therapy and that kind of thing.
So Mike and I, when us three met, he had brought this up, and it just struck me, as far as insurance companies, if they actually took care of that, take care of yourself more, and you can pay,
Yeah.
If you actually did the right thing for a longer period of time prior to getting to that point, then their payments would be less, so they should actually pay up front,
Invest
a little more in
save
prevention,
a lot,
and rather than dealing with the consequences now, because I think the insurance companies are still on the hook for rehabilitation centers and all that stuff, which is not cheap. It's big business nowadays, actually. So if they had spent the time in treating properly, they wouldn't catch it on the back end.
An ounce of prevention is worth a pound of cure.
Yeah.
You hear that, guys? You can next time you go to your doctor's office, you can throw that at them, and then sound like you know what you're talking about.
And I don't want you to say that I'm completely anti-medications, because
I'm not saying that. You're one of the rare birds. You have to do your job, and you explained
Absolutely.
yourself perfectly that you do an assessment based on risk and what the needs are of the patient, and you seem like you delve into it really, each patient as an individual rather than. I mean, it's almost, when we're talking about this, guys, it almost feels like I'm talking to one of the school committee members and the standardization of a student. Here's your chart, 1 through 10, you're going to get this, and if you qualify for this, we're going to give you that. And it seems like that's the medical profession as well at this point, where you had said we're not doing it right.
Yeah.
just a thought. I mean, it's 2018. We have Skype. We have smartwatches that can track your blood pressure and all that stuff.
Mm-hmm.
How about doing visits right out at your home? And you could sit and bang out 20 wellness visits in the office.
You still lose that personal touch. There's nothing,
I knew I'd go on a whole different.
You're
We're not talking about
on
opioids
tangent
anymore.
and I don't think that's all or nothing either, because there are certainly instances where people may not be able to get to care, et cetera, but there's nothing that can replace, that face to face, because there's something about that bond and that relationship. There's a lost art to this, and
Yeah.
the most important thing is to truly listen to people. And we again, like you said, there's many people out there that are frustrated that we're sitting on our computers all the time, and that we're not truly listening. And I think that if we're going to have a real revolution in medicine, it's going to be getting back to truly listening to one another, and it's a two-way street, right? So
Absolutely.
So one of the things is that we have to actually, like I talked about, we have to empower patients and realize that their participation is equally important, or actually probably more important. And I really think that we oftentimes tend to be guides, or should be guides, or coaches, to try to help them get to be the best they can be, and make negotiations to try to figure out, challenge them a little bit. Hey, your blood pressure is not quite perfect, or whatever the issue is, and say, why don't we change a couple things here, or you're having a little trouble with pain here. Maybe we can do a little physical therapy, a couple other things, rather than just settling. And then I don't want to say settle, but medications are there for when we need it, but we need to try to make sure that we've exhausted all the other things that we can do up front.
Yeah. I don't know who I was talking to, but I'm sure you'll agree. Can't you picture Mike showing up with a little leather bag, going door to door like the old-fashioned way? I mean, he runs around all day long anyway, so it's fitting for him,
Yeah.
And just do home visits like the old school doctors. I forgot who I said. They're like, who's the guy on? I'm like, dude, you have no idea. This guy does not stop. He's just like into everything, and like he'll go and like he'll have his medical bag here, and trombone there, and
Yeah.
and he's gonna go, he's gonna go and do something else. Let's move on to the. It's now 2018. I hate saying that because it's crazy that it's 2018, but we're moving on. We're doing assessments, risk assessments. We're looking at patients prior to actually the prescription, and we're looking for certain traits.
Right.
In that, I'm going to start off with the adults and patients, and then we're going to move into the preventative program that Mike was discussing earlier. How does it work now? What are you looking at in patients? Is the training getting out there enough to physicians where, I think at this point it should, where they're actually looking more at just the patient, like there's your arm, it's broken, and they're looking more into the head of the patient and saying, you're at risk, you have these behaviors, you have this past, I know you're in pain, but I have to think about an alternative for you as an individual.
Well, I think that's two-pronged. I think, one, you have the importance of a good relationship with your primary care doctor or your main doctor, because they're going to understand your social background. Did you have a father who had alcoholism, so do you have a higher genetic predisposition to a dependence and addiction? Do you understand the risks of what you're about to take, in addition to the benefits, that you may become physically dependent upon it and what the withdrawal symptoms physically feel like. But then there's also in the ER taking it's hard to take a good long history in the ER, family history. Do you have a family history of drug or alcohol addiction, personal history of drug or alcohol addiction? I can't speak for my counterparts in the ER, as to how each individual does it, but there's an importance right now of when I think a doctor is going to prescribe a medication in a setting such as the ER, where you don't know the patient intimately, that you need to ask that question and be upfront about it. We need to get rid of the stigma that goes along with it, and the fear of alienating or insulting your patient by asking them that, because a lot of people.
No, we're at the point now where that's got to go out the window. I've
Yeah.
discussed it in past shows, and I've talked to people about it. The stigma is just, let's put it away. Whether it's your neighbor
Yep.
Whether it's you, your kid, at some
Yeah.
point, this crisis is going to hit your doorstep. And
And-
whether it's somebody robbing your house for drug money,
Right.
or whether it's your friend overdosing, or
Right.
your son dying, or
Right.
whatever, the complications from hepatitis getting you because of intravenous drug use. At some point, everyone in this world is going to be affected by this. So the stigma just has to get thrown out the window, and we just have to say, hey, listen, man, this is what I'm seeing.
Mm-hmm.
It may create some tension. I don't know how
One way that I know that a lot of doctors' offices are doing it are that anybody who gets this prescription signs a paying contract, which is I agree to bring in that drug with me at every visit and agree to random pill counts, to random drug screening to make sure that drug is not being given to other people or diverted, as we call it.
Is that a
and I
an
think-
office policy, or is it a statewide policy?
It's not statewide. I think that there's a lot of push
For it.
from risk management to do that. But the benefit of doing that, though, is that it helps with the stigma, because if everybody gets it, no matter what, it kind of takes away, that, like when doing a history, I asked every one of my patients, regardless, when I would admit somebody, if your heart were to stop, do you want me to
Yeah.
to work to restart?
DNR.
No matter what, I ask every patient.
Yeah.
But I would start the conversation with, I ask every patient. So I think offices and doctors are starting conversations with, we do this with every patient that we give this medication to. I'm not saying that, you are going to become addicted to it, or that you are not, but this is an agreement if you're going to take this medication. And it's part of helping me to monitor you and take care of you better.
Yeah, awesome. The $1 million question. I'm gonna have to ask this. I've gone from here to here, and then I had a very smart woman who's pretty good looking too, my wife. Really throw some light on it. She shed a little light on it and put it in a way where I said, wow, I feel this way, and now, especially after doing a few episodes and really learning more and being less ignorant, quite frankly, is addiction a disease? Now, before you answer that, Dr. Mike, we speak of diabetes.
Right.
And you are one guy that I know that's like, listen, exercise, eat right, blah, blah, blah. And diabetes, not type 1 diabetes, type 2, right? Am I getting confusing the two? Is pretty much self-caused based on diet, non-exercise, and whatever. And then it becomes a disease. And it was a choice of yours to eat and not exercise properly to get you to that point. Now, and then it becomes a disease. You're diabetic now.
Mm-hmm.
Is addiction the same way, or is it a disease? But I really, my wife's like, well, what about diabetics that really make themselves get to that point of being diabetic? It was a choice to get there. How do you feel about that analysis from my very intelligent and beautiful wife?
Yeah, so I think that addictions are diseases. And again, the brain chemistry changes. And if we look at the reward center, especially the dopamine levels in the frontal cortex on patients that have addiction, say, for example, they're set at a certain level of where normalcy is. If they take a substance, and whatever that substance may have, what an XYZ effect, oftentimes what happens is those patients now crash, never coming back completely here, and then they're always, they're just
Trying to get back up.
They're trying to get back up, and again, and they're dealing with the emotional components, they're dealing with the physical addictions. Again, from opioids, it's like having the worst flu ever, right? So that's how patients feel if they're in withdrawal. So I do think that, when we talk about, a lot of people are right in a lot of ways, and, not to be wishy-washy, but I think that what our goal should always be is to reduce exposure. And I think that there are some, in trying to help people make sometimes decisions or choices, are those that are vulnerable and may have certain personality traits. They may have anxiety, they may have hopelessness, they may be the sensation seekers, they may be impulsive. And try to recognize those people to try to get them to understand themselves before they make a decision. Because again, when we look at the youth, their risk of addiction is significantly higher than somebody after the brain is developed. So you never know who is really going to be the person that's going to say, there are many people that try substances and they don't become addicted. But you don't want to take that risk with a young person, especially as their brains are developing. So I think the question is being able to say no first time. Some people can say no first time, but some people may have certain personality traits that put them at higher risk to not say no. But once they're in the throes where they have both physical and emotional addictions, there's no question that appears to be consistent with the disease, and it's much hard. And again, even for those that have tried to stop, what we do know is those that go on abstinence only, they look to only be able to stay in long-term recovery at about 10% over long term. And many of those that have the most success are actually those that are on medication-assisted therapy, which may be Suboxone, methadone, or also the longer-acting medication, Vivitrol, which has been looked at more recently, again, in some studies. So what we have to realize is that those things, and some people think it's trading one for the other, but what I would say is that it's not just willpower. Those people that are in the 10%, so 10% of the people, or roughly 10%, some of the studies would suggest are able to go abstinence only, and then there's another subsection. And I think that the important thing is we need to understand as a society that it's not one size fits all, and that what we need to do is to have enough compassion and open-mindedness to say, hey, that person's doing really well with that. They're very functional. You wouldn't even know many times. Yeah. And that other people that have gotten through and that they've abstinence only, that they don't, sometimes there's those in the recovery community or some people that say, hey, I was able to do this. Why can't you? And I think that we have to have both. Everybody has to say, whatever works, we just want to keep people alive. And the bottom line is that we have lost far too many young people. And it is, as any physician, it has affected us directly in one way or another. Again, I've had to see people that have sometimes barely survived the cardiac arrest that can occur with an overdose, and not to survive long term. And again, this is where we all have to put down our judgments, our preconceived notions as to what we think, and just say, let's just help. Whatever we need to do, we're just going to do a better job of listening and helping one another, and trying to figure out, again, the medical community has to continue to systematically look at what works for people and what doesn't work. Whether it's pain management or it's in the recovery, we need to do a better job of saying this is well studied and this seems to work. And also be open enough to see where other people's stories that they've been able to get to where they need to be. Because actually one of the things we don't do a good enough job of is really listening to the people that are in long-term recovery, because they have so many things.
They're the experts.
They're the experts. Yeah. And what we really need to do is they need to be involved so we can help understand, okay, this worked for you. I'm hearing this story. This thread seems to be consistent. How do we do more of that? Because sometimes even as doctors, we sit here and go, well, we think we know what's right all the time. And that's not how it works.
Yeah. Bonnie, we keep getting asked, and Jeffrey really got angry because I haven't asked it yet.
Okay.
Cannabis as an alternative for pain management. How do you feel about that as a physician?
I don't think that there's enough information. I know, Jeffrey, that's not the answer that you want. We go back to studies. We keep going back to this topic of, learning more about it. I don't think there have been enough studies to say that, A equals B by more marijuana, or marijuana being more freely available without the legal repercussions, that equals a decrease in opioid. People want to make that causality because I think that there's been some,
There's been some studies out of Colorado that say that, but you touched upon it before the show.
It's I think right now what we can chalk it up to more is a coincidence necessarily than a causality. But I can't say that without there being more studies. But the gateway thing, I think,
Yeah,
is what the question is.
absolutely.
That's the magic word that
Yeah.
people want to know. Is it a gateway drug or not?
Yeah.
I don't know, but it goes back to, the young brain. Why are kids why are they smoking marijuana? What is it relieving in their life? What is it replacing in their life? And the brain is very, before 25, before it's fully formed, it's very influential.
Mine was like,
Yours might
36,
still, I think yours still working on it. Let's talk to
my
your
wife
wife on
will tell you,
that one.
I don't even think she's convinced yet. And I'm 40. We keep talking about the brain being developed.
Yep.
And Mike had sent me some literature on Preventure. It's
Right.
being implemented in Plymouth. It targets high school and middle schoolers with high risk personality traits.
Yep.
You've had a conversation with the founder.
Mhm.
Tell us more about preventative and how it works and why you think it'll work in New Bedford.
Well, I think that their program is not well studied as some of the others, but I think that in Plymouth they really realized that they really wanted to start doing something now. And I think that when you start to look at the kids that may be higher risk than others, again, part of the problem, it's tough being a teenager, and some of these characteristics are going to be normal teenager. But what they've done with the Preventure program is that they've identified people that score really high for the 4 things that we touched upon before: anxiety, sensation seekers, impulsivity, or hopelessness. And what they do is they do trainings that their practitioners and sometimes teachers may be able to provide cognitive behavioral therapy. That is, I think it's 90 minutes that has been looked at to try to improve their ability to, again, make decisions and help them through those things. So that program there, I don't know all the results there. Again, this has probably been their first year that they've been doing that, but it seems to, again, one of those things that we'd love to have more data, but it seems to make a lot of sense that those kind of personality characteristics. But again, sorting that out from what's being a normal teenager at times, it's really trying to find that people that score really high on that spectrum of those different things.
I've been saying it for a while now. We're at a tilting point where we keep throwing money at those that have already been affected, and we're almost forgetting about, taking care of the roots, which is our children.
Yep.
I think programs like this are very, very important. DARE was kind of just a fly by the seat of your pants experience that really did nothing. Everyone I talked to that I grew up with was like, what was DARE all about? I remember I had the shirt and I used to smoke pot with my shirt on. It was like one of those things, and I'm like, I don't remember what DARE did, and poor Nancy, but, and just say no and this and that. Now, it's more to it. There's science now, and we have evidence that there's science behind it, and personality traits and risk assessment. But that also entails the constitutionality and HIPAA laws and whatever of assessing children. And as a parent, if you were going to assess my child on his risk of becoming an addict, I'd be like, do what you got to do.
Right.
How do what do you feel about that?
Well, I think that we need to have global education as well. Every kid needs to be taught, about the risks.
Yeah,
we need to have
absolutely.
a better program than DARE out there.
Yeah.
I think that, what the program that Mike is talking about is really valuable, because if your kid's guidance counselor at their school called you up and said, we do these risk assessments on all the kids, again, make it a standardized thing. Your kids scored really high.
Let's talk.
Let's talk.
Yeah, absolutely.
And we
It's a
potentially
no-brainer.
have this program that could, make a big difference for them for the rest of their life. And wouldn't that get your buy-in on that as a parent?
Yeah. And I mean, we're not talking about marijuana in general. We're talking about risk assessment on opioid crisis for the most part. He's timing in on marijuana. He's, these marijuana guys, one thing, they stay on the path. You know what I mean? They fight the fight and they stay on that line. We're talking about assessment of children in general, of getting them with any risk of addiction, whether it's opioid or alcohol or any type of behavior of risk, and assess the risk factor in that individual. So it's not about marijuana, Jeffrey. We're talking about all drugs in general. And yes, marijuana is still a drug, whether it's legal or not. Sorry to digress, guys, but it's just 20 comments in a row of
That might be
marijuana. You're not doing it right. You're not doing it right. Well,
You could have a whole another series.
we're gonna do a
just on
weed show.
marijuana. Yeah,
Mike's
I mean, you
working
could-
on it.
yeah.
Trust me, we're doing it,
Yeah.
and it's gonna stink
Yeah.
in here, but we're gonna do it. You know what I mean? Wear your gas mask. Charlie Baker's trying to get 72 mandatory hours of confinement. I'm a libertarian. It's basically he's proposing a bill to let cops and medical professions hold addicts who are deemed a threat to themselves for 72 hours before obtaining a court order. As a constitutionalist,
No.
that's just like that's bad. That's very, very bad. As a friend of a loved one, I might actually be cool if I saw my buddy in and out of overdose. You got these people that are getting Narcan twice a day.
Hey,
If you could say, hey, before he can get to the courthouse, lock him up and keep him alive, and I'll go there and try to love him for 72 hours and convince him to go
Right.
to further treatment. I see that end of it too. But as a constitutionalist, I do not want any, because I could see this going real sideways, real fast, and petty crimes, you can pinch a guy for something small to get information on another guy, and next thing you know, you're holding this guy for 72 hours saying that he's a risk,
well,
and there's the problem. But
yeah.
I can also see the other end of there are family members that would love that 72 hours of comfort knowing that their child has another 72 hours to live in a setting where they cannot get high anymore.
So as, parallel to this, let's think about as a family member of somebody who's had alcoholism and, and still has a struggle.
Yeah.
They have been in and out of the ER, drunk, and, been pulled in. And, I think that's a very slippery slope, when you start saying that, there's a 72-hour law right now for people who are suicidal or homicidal. Very actively saying, I want to kill myself. If somebody comes in who's, just been revived with Narcan, comes in and says, I want to die. This is how I'm trying to kill myself. There's a clear line there for holding them for 72 hours. But can you say that, the person who goes out and eats McDonald's trying to kill themselves because they went out and had McDonald's? Because they're going to have a heart attack down the
Don't
line?
say that. You'll have people on
Well,
CNN
I
asking
know,
for the president to
coming
get
down the
locked
line.
up for 72 hours.
But I think it's a very slippery slope when you're depriving, people of their civil liberties. And
I'm
it's
all about it, yeah.
horrible addiction. It's a horrible disease for families.
But
to
can
go
you
through.
see how,
I can
as a
understand-
mother, as a brother, as a father,
But
God, lock them up for 3 days. I know many parents would love that, and just the chance that, they haven't seen their kid in 2 weeks. Next thing you know, they're in the hospital. They get that call from a friend who's a nurse that shouldn't have called, but, lock them up, please do something. And they're saving them, and they give them that chance maybe that they didn't have because they've been on the run for 3
you can't
weeks.
force somebody to get treatment.
No, you can't. That I understand
and I think
that,
by
but
holding somebody 72 hours, you're more than likely alienating them from the very people that they need to be embraced by and feel okay to come to when they are ready for treatment.
everyone I've talked to on this is you have to be ready on your own.
Mm-hmm.
And it does take help at times.
It does.
Those interventions sometimes work. You're right; they catch you at the right time when you're ready, and it was just the right place, right time. And so you always got to keep trying as a loved one to love that person
But that comes from a
back to
loved,
life.
But that comes from a loved one.
Yeah, absolutely.
But-
how do you feel, Mike, about this?
Yeah, I think that I think it's well intentioned. What the goal is to try to get people treatment, and I
Yeah.
think that we're all very frustrated with the fact that the deaths that we've seen from the opioid crisis is unacceptable, but I do think that what you say is it's a very slippery slope for those people to be kept against their will. It's a tough one. Now there is a Section 35 for those that are serious harm, and that's court ordered, as you know. But
There's due process if it's court ordered.
yeah, but I think that it is one of the things we're doing here in the city of New Bedford, and I'm really proud to say that we've been able to increase that, is that our ride along program. We're getting out there, as you interviewed Jamie. We're going out there afterwards, trying to find these people and connect them. We're also, with the drop-in center, we're giving people an opportunity, non-judgmentally, to come, and we've been able to get some people to treatment, from those touch places. And I think that we just need to figure out ways when we can find people that they're able to have a conversation. Sometimes when they're in the emergency room, and they've come down off of their high. They're not always thinking clearly. They're not, they're very frustrated and angry, and it's hard to catch them at the right time there. And I think that it's I think it's something that we should all continue to talk about. I think that, I appreciate, the real care and concern that people have and why people are, would like to have that happen. But, I don't think that that's something that we're going to be able to do. Certainly the
By force.
American Civil Liberties Union has really been all over this, obviously. And let's have the conversation, and that's the most important thing. And this is why these shows are very important, is to have conversations.
Yes.
Is that we all learn, and that we come at this, and maybe we have some more public forums, that we have the opportunity where people can talk about and we can all learn from one another. And people have great ideas out there.
And you don't have to be a medical professional to have an idea.
No.
It seems like every show I do, I pick up, I'm like, wow, that's a great idea. And it just, and it snowballs. And if you keep having this conversation over and over again with different people, and you get the word out there, at some point, some light bulb's going to go on this guy's head, or the user, the family member, or whatever, and it's going to help move the process into a better direction. I'm getting yelled at by my producer back there. It's 8:02, guys. He's really pressing it. 2018, he's being mean to me. Plus, I owe him a six-pack for his birthday. One last thing, Bonnie. Anything that you are interested to bring into this conversation quickly that I missed?
That, I think we've already touched upon it, but really going back to it is that it can be anyone. It can
Absolutely.
be your neighbor, your son, your daughter, your straight A, brother that, graduated from Harvard Law. It could be the person, unfortunately, living in Buttonwood Park, in a tent. It knows no boundaries.
It knows no boundaries. I always say that the devil is going to show up on your doorstep one way or the other
And,
when it comes to this.
Going back to, we need to have more compassion and empathy for people who are dealing with this.
Love people into the right direction. I've learned that. I was that guy that at one point was like, man, 3 Narcans, you're done, dude. And God, I was horrible. And, I'd go to church on Sunday and I'd say stuff like that. And, you get caught up in it sometimes. And I'm a human being. And I've learned. And I'm glad I learned, And that's why I do these shows more, and I continue to do them.
Yeah.
Because I'm hoping that each time one person at least catches it on their phone, learns something, and maybe helps somebody or whatever. Mike, your last thing. Well, your last 3 things, because you're going to plug 3 walks.
No, I'm not going to
2
plug.
band sessions.
We'll do that another time.
No, man, feel free. This is you. This is us saying thank you for being such an important part of the conversation.
I think that one of the things is that there are many people out there that have become very frustrated with doctors, and I would say that many doctors out there, most doctors care a lot, and that I think that a lot of people are we're all trying to figure our way out of where we're at right now, and that we want from the people that we work with on the opioid task force, the physicians to prevent opioid abuse, the nurses to prevent opioid abuse. There are people out there in this community that really care. The first time as a physician group, and I will say this, that I know of no other physician group in the state of Massachusetts at the very least that has got together and said that we're all going to try to figure this out as best we can. 21 doctors showed up, and we're sitting there out to dinner, and everybody from every organization, whether it was South Coast, private physicians, the ER, pediatricians, Hawthorne, the health center, everybody showed up and said, we can do better. And I think that what we're continuing to do is that our goals are to continue to be advocates. What needs to change? What do we need to be able to be a voice, to be at the table? And, I think that that's the important thing. Physicians are not we're not going to fix this problem on our own. We're not riding in on our horses, but we need to be part of the discussion.
Absolutely.
And I think that the other things that we need to continue to do is for our outreach for public health, to continue to do programs like this, answer questions and help educate the public, the kids, on what we're dealing with, and also on the other end to continue to have programming, which we've done in the past to try to get doctors to understand. We've had physicians from Mass General come down that really care about it, and they're very excited about the progress that we've made in their addiction center. We've been able to have discussions about medication-assisted therapy. We've had Michael Botticelli, who's been down, who is essentially the czar he was the drug czar for the country, and now is at Boston Medical Center. We've had a physician, Peter Grinspoon, who is actually in long-term recovery, wrote a wonderful book, Free Refills, that talked about how, prescription drugs and how he got himself into trouble, and now he's back practicing, very courageous, and had him down here. And then we had someone talk about pain management. We want to continue that. We want to continue to bring, because we actually have some wonderful world-recognized resources that are really 40 minutes away. And so what we want to continue to do is to work in all of these things to really continue to be part of that conversation and to really do the best we can to listen for what is needed. Because one of the problems with why we continue to struggle with this problem is there is no checkbox that says that we have it. Yeah. So we sat down again today, we had our opioid task force, and we were fortunate the state, the Bureau of Substance and Addiction Services came down, and they talked to us about there's another prevention program that we're very interested in that actually looks at K through 3, that's dealing with group and self-regulatory behaviors called Good Behavior Games, and they started this in Baltimore. And, these are the kind of people that are starting to come in. These are the kind of things that, we need to continue, attract those people to come down and partner with and help our community to do the best we can. And there are incredible people that are starting to come together, and we realize that it is not going to be that one checkbox. It's going to be learning from all those things.
It's going to be it's a fluid situation. It's going to take many of us from all different rides of life, from the producer of shows like this to myself bothering you guys and begging you to come on, to doctors and experts and police departments, and it's a situation that's continuing to develop, and I hope we're going in the right direction. New Bedford Wellness Initiative. I'm going to talk about it because it's a good thing.
Yeah. Well,
you got 2 minutes.
All right.
Go on it.
So this is the New Year's resolution time, right?
Yeah, absolutely.
So the Wellness Initiative is now really, I'm excited because people have really stepped up. The only way it grows is for people to participate, because the wellness program is not one person. It's really continued to be a wonderful group. We're doing now, because we have 10 more doctors, we're doing weekly walks at the mall now, and we'll move out to Buttonwood Park when the weather's better. Again, walking, if we could put it in a pill bottle, it would be one of the best pills for both behavioral health, for physical well-being, for your heart, etc. And our programs on Sundays actually dealing with diet, exercise, stress reduction. We have a hypnotist this week for smoking cessation. So we have massage therapists twice a month. So we've actually tried to take the things that are very expensive to people and make it free to them. And that's always 9 to 1 at the Boys and Girls Club. And all our information is either on our website, nbewell.com, or on our Facebook group and our Facebook page. And, we can...
New Bedford Wellness Initiative.
New Bedford Wellness Initiative. And so, and one of the things we realize is that, this is the time, 40% of people do New Year's resolutions, but less than 10% stay with it. So we have to understand why that is. And I think that sometimes people have probably seen enough posts from what our page is, but to continually come back, and as I think of medicine as being coaching, we have to do it with people alongside them. We can't just say, hey, I want you to do this and come back in 6 months or a year, because it never works. Yeah, and
it's pretty cool what you do. You're out there, he's a physician giving up his own time during those 4 extra hours he has in his day, and he's going through the mall walking with his patients, actually walking with anybody. He sets up these events, he's doing the farmers markets, he's getting people free massages, free yoga, free, and you're setting all that. I'm looking through the events page on New Bedford Wellness Initiative's Facebook page, and it's just fully, click on the events, go there, do yourself a favor. If you got nothing to do on Sunday, do something good for yourself, go for a walk. I absolutely love it, and Mike's a big force behind it. My phone is getting alerted every 10 minutes because he's posting something on it, and I try to stay hip with what's going on in the area, and it's like, Mike posted, and it's awesome that you do that. You are actually a physician that cares.
Yeah.
And it's awesome. And it shows people that they're not just a number or a checkbox, and we appreciate that, Mike.
This is home. This is where I grew up, and you know what? And
New
that's
Bedford
where
Chief just said that. Chief Cordero just finished saying it's awesome seeing a guy like Mike come home and take care of his community. And that's a pat on your back. He said the same thing about Mike from New Bedford guy too, though. so you weren't totally on the pedestal.
It's only Mike's, is that right?
Yeah. All right, guys. Thank you so much.
Thank you for having us.
Appreciate it. Dr. Bonnie Boerl, Dr. Mike Rocha, New Bedford Wellness Initiative, Hawthorne Medical, and everybody knows I'm a fan of Bonnie's husband, Chris, who ran for council at large. He's not done, folks. He's going to be back on the show. We're going to be talking about stuff in the city as far as no trespass orders and stuff like that in the future. Before I go, guys, last night, we're talking to a couple heroes here, physicians saving lives. We had a huge fire on Tinkham Street, and our New Bedford paramedics, police, and fire unfortunately lost somebody last night during the fire, but man, they went into a fire and risked their own lives to help strangers. And when you see a cop, a firefighter, or a ambulance driver tomorrow, buy them a coffee, say hi, shake their hand. Up on the screen, you have one of the first responders that went in there in uniform, Officer Nate Pimentel. Nate's a former Marine. Well, he'll kill me for saying that because he's a Marine for life, and he's also a police officer now in New Bedford. Nate rushed into this burning building and saved people last night. That is the face of a hero. We see it on TV every day, and it happened in our backyard last night. Nate, thank you for your service as a Marine, and thank you for your service as a police officer in our community, and thank you for being a hero, Nate. We appreciate you and what you bring and your selflessness that you demonstrated last night on Tinkham Street at a fire, saving and rescuing some citizens of the community that you work for. Thank you, and God bless you and your family. And Nate, on a side note, is the husband of Adelia, who's going to be on our mental illness campaign. She was on the show. She's a little rock at that one, and she's kicking butt, and she's going to start the mental illness campaign with us. So I actually met Nate at her show, and man, he is just this quiet, chill guy, and he was so calm, and he's such a nice guy. And then you look at him, and he's a Marine Corps sniper, and he's running into burning buildings. You would never think that about him when you met him. He's just so calm and cool. Great guy. New Bedford, thank you. Greater New Bedford, thank you. Thank you to our guests again. Your time is appreciated. People that like the show, I'm just the guy that pokes and prods a little bit, and I got some awesome guests that fill in the rest. New Bedford Guide every Thursday. You have my show, 7 p.m. It's called the Chris Resendes Show, I guess. Nobody really cared to give it a good name. You got my my little cartoon that Josh made me up on the screen. Again, thank you for everything. Next week, big topic that I really want people to look into during the week. If you get a chance, just Google human trafficking New Bedford, human trafficking Fall River. We're going to start that now. We've done a few opioid conversations. We're going to start talking about human trafficking, which is almost tied into the opioid conversation as well. It's real. It's here in New Bedford, and we're going to talk to some experts from police to members of South Coast Hospital to ministries that are out in the streets helping these individuals that are being held and trafficked throughout our community. Thank you all. God bless. Have a great night, and be kind to each other, New Bedford, and walk.